So to start off this session, it's my pleasure to introduce you to the two next speakers. I'm told that it is a tagging team. First, Dr. Herman Barkema, my colleague from the University of Calgary. I think that Herman at this point needs no introduction, but nonetheless, I think being a member of both the Faculty of Veterinary Medicine and the Faculty of the School of Medicine, he's a physician of many species. And he is leading, you've heard about him from the CAN-AMR-Net, but I think that it's also really notable to see how much of a builder he is. Over the years, he's built the consortia for IBD and Johne's disease, for mastitis, for One Health at the University of Calgary and AMR, the Water Institute, and then the latest one at CAN-AMR. So thank you, Herman. And with him, Benjamin Cadley, who is a PhD candidate at the University of Calgary, who has obtained his master's at Calgary working on the microbiome of dairy and beef cattle, infectious disease, and now is currently working to understand transmission of antimicrobial resistant infections in the context of One Health and using bioinformatics. So I think both of them will talk to you today about systematic review of the WHO. Thank you, Herman.
Thank you, Dao. So this is a One Health session, but we're going to only talk about human AMR data. But here is a veterinarian talking and also a graduate student in veterinary medicine. So, but Ben, who is now getting mic'd up over there, Ben, can you put your hand up, Ben? Oh, he doesn't hear me even. But my graduate students don't always listen to me. But so Ben is really One Health, and he practices it even at home because he lives together with his girlfriend, who is an MD. So he goes to the max with One Health. So I'll tell you about our systematic review that we're doing for the WHO. We were contacted in the beginning of this year to do this WHO review, and that we was John Conley and myself. John Conley is an MD in infectious disease, MD at the University of Calgary, well known, and we realized pretty quick that we could not pull this off ourselves. So we asked a young colleague, Diego Nobrega, to do this. Diego is a Canada Research Chair in AMR with a One Health approach. And he has done a great job leading this. We formed a team all over the globe. We work with a group in Indonesia, Ralph Hammers and Gilbert Lazarus and other people, and then we realized that we needed way more people to pull this off, and you will see why. So we have 32 people involved in this systematic review. 8 of them are DVMs, equal amount of MDs, 2 PharmD, one RN, and 15 graduate students that don't have these designations. So, and they're from all over the world. Because one of the things that we had was 25% of the papers that we identified were written in Mandarin. Yeah? And it is really important that you then have people that are fluent in Mandarin to work with that. So we also, because I work a lot in China, I'm affiliated with the China Agriculture University in Beijing, we got some people from there involved. And then South America, we have 2 people, one from Colombia, Andres, and one from Brazil, Leis. And then also Africa. We work with a group in Nigeria. And then from Europe, that's mainly a WHO, Anna Dean, Sylvia Bertagnoli, and Esther van Kleef, and Kavita Kotari, who is actually a librarian. When you do large systematic reviews like this, you need the help of a librarian as well. And then Lindsay Covington. And then from the Middle East, and that's Iran, and a lot of the papers we had actually were from Iran, Mohamed Jokar and Sina Salagegi. So a lot of people in a team where you need a lot of meetings and training, and Ben has given a lot of that training to these graduate students, because you need to not only use the same criteria, but you really need to understand which papers actually you can include and which ones you cannot. So this review is actually because WHO, the GLASS report, had a global antimicrobial resistance and use surveillance system, is not complete. And you will see in the next slide what is involved and what is not involved, but you will see that some countries don't provide data to GLASS, and a lot of those countries actually have a very high prevalence of AMR and also of antimicrobial use. So GLASS does a lot of things. It also has antimicrobial use that it does, the GLASS AMC, and other reports that it makes. So if you then look in the world, and these in blue are the countries that are enrolled in GLASS AMR and GLASS AMU, and then the purple ones are only enrolled in GLASS AMR. So like the United States is not enrolled in GLASS AMU. And then you see some white spots there, like China, but also countries in Central America like Mexico that are not giving any data to GLASS. New Zealand, for instance, to our surprise actually, is not involved in GLASS AMU and GLASS AMR. So that is the reason why we are doing this. We are taking all the literature out there and look how we can complement what is reported in GLASS. So if you then look further even, not the countries that report to GLASS, they even don't report on everything. This is 2022, the bloodstream infections, and then you see like a country like Russia is not reporting at all. And from the United States, we don't have data on bloodstream infections in GLASS. So it is really important to fill up these gaps. And this is then for urinary tract infection, and it's even less. Yeah? Bloodstream infection has the most, but urinary UTIs, we have a lot less data even. So there are some pitfalls with this WHO global surveillance. There are data sharing, privacy concerns that plays, for instance, in the United States, a big role. And data are grouped. There's no real risk analysis. There is no, we don't look at women versus men, children versus the elderly. We don't look at primary care versus tertiary hospitals. There are all kinds of things that we really would like to know that are not in the GLASS report. So, and many countries have limited capacity for AMR surveillance. And a lot of the data actually come from these tertiary, mainly university hospitals. So then clinical definitions can be a problem and be different from country to country. When you look at UTIs, what you get, is it colonization or is it infection where you actually look at it? It depends a lot what data that you get, and countries just report, and it is possible to do a quality control of what you get. So the level of care I already mentioned, community, hospital acquired, and then the question always is, how representative is it for the country? If you get data, we don't get data from China, but let's say from India, does it come from the Punjab, or does it come from the south? Does it come from a city, or does it come from rural areas? Typically from cities. So we look for this because a lot of countries don't report to GLASS, and we want individual level data. We want representativeness to look at the quality of what we have. And then additional information, we would like to have strain level information. And all the data in GLASS are phenotypic AMR data. We also would like to look at genotypic AMR. And we won't report in that in the first round, but we are not, for every manuscript we also are marking whether there are genotype types available, and so that we can do another analysis of it. So, and then we want to look over time. So we are actually looking from 2010 to 2024. For the first report now, we only look from the last 4 years, but we're working on 2010 to 2024. So our objectives are to contextualize these data with AMR data from the published literature, look at the gaps, and then produce country and regional level estimates adjusted for patient level factors. And WHO groups countries according to the region that they're in. But there is an enormous difference within a region. If you look at Malaysia and Singapore, two adjacent countries, Singapore being the richest country in the region, and a country like Malaysia, one of the most poorest country in the region. So you will expect different antimicrobial use and antimicrobial resistance estimates. Then over time, I think it's very important to see what, for both antimicrobial use and AMR, but we're focusing here on AMR, how it is developing over time. And then we are going to put all the data in a computer database so that other researchers can use it. This is, as you will see, and Ben is going to present it, it's a very valuable source of data for research. So this will be, we work with Oxford on that. It will be, we will be all be categorized and be accessible for further use. So Ben, you do the cool part of the presentation.
Okay. Oh, my mic is on. Perfect. Okay, so thank you, Herman, for that introduction. Very, very nice. So what I'm going to give is a brief overview of the methods that we're using currently to conduct this systematic review, and also give you a sneak peek at the results. Just a little bit of a note that this work isn't completed yet. Like Herman said, we've focused mostly on the previous 4 years so far, and we've got an additional number of years and quite some papers left to screen through and extract data from. So this is just a sneak peek. The data that I'm going to show today and more will be available in the GLASS 2024 report that should be out sometime in January. And then the full report will be out late 2025 with the full paper. So I will get started here. So for this systematic review, we pretty much explicitly just use the pathogens and the clinical syndromes that are involved in GLASS. Makes sense, I don't really have to explain that. So the 5 clinical syndromes: urinary tract infections, bloodstream infections, lower respiratory tract infections, gastrointestinal tract infections, and central nervous system infections. All of these pathogens are and have been in the GLASS surveillance system for the past 5 years or so, with the exception of Candida, so antifungal resistance for the bloodstream infections. That is something new that GLASS is doing. So we're getting started surveying that at the same time GLASS, which is quite interesting. And then for each of those pathogens specific to the individual clinical syndromes, we have individual pathogen drug combinations that we're doing surveillance for. So all of this matches the GLASS surveillance report or surveillance system as well. This is about 50% of the pathogen drug combinations that we're interested in. I can show the full table because I only have one slide. But each of these different symbols within this table represent an individual pathogen drug combination specific to a clinical syndrome. So it was quite extensive, the amount of work we're doing, not just the amount of papers that we're looking at, but also the amount of data that we have to extract. Because, for example, for the bloodstream infections, we have 17 pathogens that we're interested in, and then several different pathogen drug combinations within that clinical syndrome. So quite a bit of work, and that's not only the data that we are extracting. We're extracting the AST data, obviously, but we're also looking at the clinical syndrome, the sampling years, so we can do the trend analysis over time, the country where that data comes from, healthcare level, so tertiary, secondary, primary levels of care, origin infection, so is it community-acquired infection, hospital-acquired infections, very important questions there. Age and gender are definitely things that we would like to adjust our prevalence estimates for. We saw yesterday, I believe, one of those charts, those figures showing the prevalence of AMR for different age, with it being quite biased towards elderly folks. So it's something that we very much need to adjust for where possible. Individual hospital wards, so the cancer wards, our emergency care, ICU, where is the AMR actually happening? Inpatient, outpatients related to origin and infection, but we're also looking for a lot of things in our quality assessment, like pathogen ID method, AST method. Are they following CLSI guidelines or UCAS guidelines? Using ECOFs? We want to take note of all of that so we can assess for the quality of this data. And then, as Herman mentioned before, we take additional data like MIC data, yes or no, strain data, yes or no, marking each of these individual papers for folks like colleagues, you guys. We just have that resource of what published literature is actually reporting genotypic information in case we want to look into that further after this work is done. Okay, so for our literature search, like Herman mentioned, GLASS is from 2016 on, but we are including 2010 up to 2024 data, just to get a little bit of a history before GLASS actually started, to provide a baseline for their measurements. So together with Kavita at the WHO, the librarian there, we searched the literature. We looked through Medline, Embase, and I think the Global Health Database, and we found quite some number of titles and abstracts, over 14,000 for bloodstream infections, resulting after that 6,000 full text that we had to screen. Lower respiratory tract infections, another 10,000, UTI, just over 7,000. When we saw the central nervous system infections and the GI searches, we did a little bit of a phew, so we had a little bit of a break there, which was definitely nice to see after the extensive work we've done for the other 3 syndromes, but still quite some work, and it's very, very comprehensive measure of what's available in the literature. So after we extracted the AMR prevalence data, we did multi-level random effects meta-analysis, transform those proportions using an arc sign transformation. That just keeps the confidence intervals between a proportion of 0 to a proportion of 1. So that's basically all that transformation does. Each pathogen and microbial combination was fit separately in different models, subgroup by region, as per WHO guidelines, and then we had random effect for study ID and enforced country as a random effect too, because country AMR prevalence tends to cluster within country, so we put that in there too. So all of this systematic review data and process followed PRISMA guidelines quite heavily. We have our protocol published in Prospero, so if you guys want access to that, feel free to send Herman and I an email, or you can just search for it on Prospero yourselves. So I have the bloodstream infection, urinary tract infection, and gastrointestinal tract infections here so far. These are the ones that we've been focusing on so far. So these are the ones that we have data for the past 4 or 5 years. So we started with 22,000 titles and abstracts. After the literature search, after deduplicating that, we ended up with just over 15,000 titles and abstracts that we screened through. From there, we had 7,000 or 5,000 full texts that we ended up screening. So far, we have screened all but I think 1,200 of those full texts. So we've already screened 4,000 full texts, which is quite an extensive amount of work. And then we ended up with 752 articles eligible for inclusion so far, and we have done data extraction on 300 of those so far. So I'm going to talk a lot about the bloodstream infection sides of things as kind of a case study for you guys, because we just don't have enough time to go through the 3 infectious syndromes that we have data for. So going into the BSI, we have just over 300 reports actually extracted. We anticipate having around 1,300 total papers that we will have to extract data from. But here I have a map on the left of the actual countries where we have data from our published report. In the light green, we have very few studies reporting from those countries. And in the dark blue, we have quite some number of reports from those individual countries. You can see most of our papers come from the Middle East, Southeast Asia, and mainland China. And this is really important because a lot of the AMR happens in Southeast Asia, where AMR prevalence is higher, in the Middle Eastern regions, in China. And as you remember from those earlier figures Herman showed, China is not included in GLASS surveillance. So we're providing GLASS in the WHO, something that they don't already have. And in the right panel, we have the number of reports per individual pathogen for bloodstream infections. And then on the far right, we have the number of isolates that we were actually able to extract antimicrobial susceptibility testing for. So generally biased towards E. coli, not really surprising. One of the top causes of mortality for bloodstream infections, one of the highest prevalent pathogens for bloodstream infections. So it kind of makes sense that most of our data surrounds E. coli, which is kind of a good thing, I would assume. And then once we compare the distribution of our data against the WHO, you can see a lot of similarities. Like WHO only reports Canada, North America, and then we have Canada, the USA, Mexico. Generally, our data covers a little bit more there, maybe a little bit less in South America, maybe a little bit less in Africa. But I think we more than make up for it with some of the countries that are missing and a higher representation of countries that have a higher AMR prevalence in our published literature review compared to WHO. So together, they come together really, really nicely. So moving on to the actual prevalence of pathogens. Now this is kind of most of our data summarized here. It's kind of hard to see, so I will zoom in just on a case study of E. coli here. So here we have E. coli. On the far left, we have the antimicrobial classes, stratified by each individual antimicrobial. At the bottom here, we have our percentage or prevalence of AMR. And then on top, we have the individual regions. So our global estimate and our African region estimate, region of the Americas. Now you might think region of the Americas, what's that? That's North America, Central America, South America. Seems kind of odd to group those 3 together in AMR terms, because you might think North America might be better off than South America in terms of AMR prevalence. That's true. This is just how the WHO stratifies their data or groups their data. We will also be doing country level estimates. We just haven't got that far with the data yet. You'll also see that some bars are transparent, and we did that together with the WHO. We've kind of made a cutoff of 4 countries being the cutoff for a little bit more reliability in our actual regional level estimates. So these transparent bars are our estimates where we have less than 4 countries reporting to that estimate. So what we find here, at least in the preliminary data we have so far, is that carbapenem resistance is quite low globally, except for when you look towards the southeast region. But then there we have some large confidence intervals. Again, this will get, these confidence intervals will become tighter. Our estimates will become more precise as we get more data. We still have probably 1,000, if not more, papers that we need to extract data from. So this is actually quite exciting news already so far. And now when we look into Staph aureus and methicillin resistance, this is a really important case study to look at because this is one of the sustainable development goals for the WHO and something they want to monitor and decrease over time with their surveillance system, just as a mark or target for countries to reach. Again, we find it quite high overall, except for in the European region. Generally have some bigger confidence intervals, but this is preliminary data, and we'll be adding so much more data points to this, so it'll only get more accurate. Big thing is to compare our data to the WHO GLASS report. So on the left here, we have our published literature, and then on the right, we have the WHO GLASS reports for third-generation cephalosporin-resistant Escherichia coli. And our results measure up really, really well with the WHO GLASS data. Our estimates are a little bit higher than the WHO GLASS data right now in terms of AMR prevalence, but that's just a product of the WHO GLASS already having adjusted their data for things like testing coverage that we haven't been able to do yet. And then one kind of important difference that we've seen so far is our European region estimates are quite a lot higher than the WHO GLASS regional estimates, and that's just because of the countries that we've had included in our reports so far. We've had a lot of southern European countries like Italy and Greece, and Cyprus, where prevalence of AMR is higher. And we don't really have a lot of representation from northern European countries yet that we've extracted in our published literature systematic review. So take that with a little bit of a grain of salt. And so, yeah, Herman mentioned that Diego Nobrega is working on a dashboard to visualize all of this stuff. So allow me to brag on his behalf because I think this is really, really interesting and important project that he's working on. So something that I think is lacking in a lot of this work is making all of the data open, the raw data especially open and publicly available and really easy just to download. So this is something Diego, Mohammed Jakari's PhD student, and a biostatistician, Tyler Williamson, have been working on, making a dashboard and making all of this data publicly available to folks like you, public health experts, policymakers, to make more informed decisions on AMR and for interventions surrounding it. So this dashboard will essentially compile the results of our systematic review alongside the GLASS report and alongside other global surveillance systems like Sentry, like Atlas, and compare all of them within one easy, convenient dashboard, essentially. So the aim of this dashboard, like you'll be able to filter the results by individual surveillance system, be able to filter it by clinical syndrome, you'll be able to filter it by the pathogen you're interested in, the antimicrobial, and then you'll see all of the country estimates that we have available for that. And then you'll also be able to see the AMR prevalence for that AMR pathogen you're interested in a particular country over time, and then see what trends are starting to emerge, and we'll give a weighted median or some other model outcome that we will decide on. But this is still kind of an early draft, just along with our systematic report. So more to come on that. So next steps, like I said early on, the WHO GLASS report should be out sometime early next year in January. That's more of a technical report of the systematic review of what we have so far, data from the previous 5 years, especially. So by mid-2025 next year, we should have all of this data extracted and analysis done just in time to get the GLASS 2025 report done, that full systematic review, incorporation, and full contextualization of the actual WHO GLASS surveillance data. And then also that, along with that, will be the completed AMR dashboard that Dr. Diego Nobrega is working on. So with that, I'd like to say thank you guys for listening, and Herman and I would probably be very happy to take any questions.
There's time for a brief question.
Hello. Greg German, Unity Health. I was very interested about the Prisma diagram where you said you dropped out studies with less than 20 isolates.
Yes.
From an antibiogram perspective, we think about 30 being the sweet spot, not 20. And perhaps because you're doing a compile of others, why would you have a cutoff anyway?
Right, which is fair. So there's two reasons for that. Well, generally CLSI recommends the 30 isolate cutoff. we ran our own statistical power calculations just to double check that, and we ended up with a 20 level cutoff. So that was kind of the main reason for that. If we included, isolates or papers with 1 to 5 isolates, maybe a little bit more, I don't know how much use we would get out of that, to be honest with you. So our 20 isolate cutoff was based on our own statistical power calculation.
Thank you.
Thank you.
Any other question? Okay, thank you very much.